Well, good morning. Hope everybody's doing great. My name is Brady McLaughlin, and glad to have each of you with us along for the ride this morning. What a ride this is going to be. I appreciate everybody taking time to tune in, whether it's now or later in the day. Um, you saw my socks compliment of Gary Montague with Heart Hero. Check them out, hearthero.com. They're going to totally disrupt the CPR AED industry. But we'll give everybody just a second more to chime in. It's 6 a.m. Central on October 21st, 2020. This is the big day we've been waiting for the 2020 ILCOR AHA Guidelines updates. Again, my name is Brady McLaughlin. I'll dive right into it. And feel free to share this video. It's going to be posted on the CPR Instructor Network indefinitely. And I hope that this gives you some insight as to what's about to happen and how it's going to affect you and your CPR AD business, and also just as importantly, if not more important, the chain of survival. So guys, real quick recap. Last week we had a life-saving summit here in Birmingham, Alabama. A big thank you to all who attended that. I wanted to give some shout outs to our partners, Go Rescue, which is my company. It's a family of 5 life-saving brands. Also Heart Hero and Gary and his team, as well as Preston Products. We love some Preston Products, so we wanted to throw that out there. Also, congratulations to our 4 award winners. Dennis Agnew, Staff Instructor of the Year, Biddle Fire, with Biddle Fire and Life Safety as AED Distributor of the Year. Training Side of the Year, All American Health and Safety, and then the Go Rescue Founders Award, Code 1 CPR, Carl Daigle and his team. I see a lot of us on here this morning: Chris, Michael, Nathan, Tim, Anthony, Beverly, Jocelyn, or Jakin, I'm sorry, and a few others. So thank y'all for tuning in. Okay, so what are we about to do? These guidelines just got released at 4 a.m. Central, 5 a.m. Eastern today. Okay, 4 a.m. Central, 5 a.m. Eastern. So I've had just about 2 hours to review and kind of go through line by line. There are really 2 editions of the update, and I wanted to kind of break those down for you. Real quick, I run a company called Trio Safety. We're a brand under Go Rescue. We're focused. We're at AHA Training Center, Red Cross Training Center, ASHI Training Center. We've got trained somewhere around 1,600 instructors. We have some fantastic training sites. We train a decent number of students, around 20,000 a year, and that's kind of my background: public safety as well, emergency management, etc. So I wanted to throw that out there so you knew what perspective I'm coming at this from, and kind of how I want to share that with you. So this is a big day. So every period of time, it's traditionally been 5 years. The AHA has released, and through ILCOR, the new guidelines. Well, in the last few years, starting in 2015 and then 2017, 2019, we've seen what's called focused updates. And so these committees meet through ILCOR, which is the International Liaison Committee on Resuscitation, to help decide through peer reviews what's evidence-based, what needs to be reviewed, and then if there's any recommendations for treatment changes or any guidelines. So these are, clinical folks, researchers, PhDs, medical professionals, healthcare, that all come together for this. So I wanted to kind of, what my perspective is on these guidelines for all of us watching is, how does it affect me? How does it affect my students? And how does it affect the chain of survival? And when I say me, I'm talking about you in your shoes as a CPR instructor, whether that's a solopreneur or a business owner with multiple instructors, whatever that may look like. There's some things that we obviously don't have answers to, and later today, the AHA is conducting their virtual event for the virtual release. I think that starts at 9 or 9:30 Central. I encourage all of you to jump in on that. They've got it on Facebook Live and YouTube through the AHA, and then digest that. But the new curriculum's coming out, and the new guidelines are coming out. So, Philip, I see you need more coffee. Gary, Red Bull. Yeah, here's my version of Red Bull. If I was on Red Bull, I would be bouncing off the walls right now. I'm just excited to see what's going on. Cheryl, hope you're well. Been praying for your recovery. Gail, glad to see you also. And I'll periodically check back in and answer questions as I see them. So, there's some things you'll notice that have not been considered since the 2010 guidelines, These folks arrive at these consensuses again based on evidence, and then they categorize the evidence and the recommendations based on a weak or irregular occurrence, but a strong recommendation. And there's different matrices. So when I post the links, which I will on the comments to this, you can go back and review those. So some big things you may want to know right off the bat. 30 to 2 remains unchanged. We're still doing 30 to 2, guys. Compression to ventilation ratio. Also, some things is we're still going to be the same 100 to 120 compression per minute range. We're not seeing any changes at all in compression depth for adult, children, or infant patients when it comes to BLS algorithms. So those fundamentals are going to remain unchanged according to everything that I've seen so far this morning on the 2020 guideline updates. Some hot topics. So I'm going to kind of start with some hot topics and address those, and then go into the BLS algorithm. I'm going to briefly touch on ACLS and PALS. I'm going to toss over to Code 1 CPR, Carl Daigle. I think in the next 24 to 48 hours, he'll be able to share on here his key takeaways from that. And then I'm also going to talk about some things that y'all want to really know about, which is the education, implementation, and teams, as well as first aid recommendations. So ILCOR does touch on first aid. So all of these updates were decided upon in February 2020. So COVID's not factored into any of these updates. I think that's important for everybody to know that COVID's not part of the equation right now in any of the thing that you'll see today. Some hot topics for BLS include patient transport, CPR during transport. Is it more effective to not transport and try to get ROSC on scene or transport? CPR before calling for help, feedback for CPR quality, analysis of rhythm during chest compressions, etc. So we'll kind of dive into these and answer any questions you may have that I might know the answer to, or that the guidelines might have. So there's a primary emphasis now on dispatch diagnosis of sudden cardiac arrest and minimizing the frequency of missed sudden cardiac arrest events as they happen in the field. So they're saying that those false positive cases happen, and we want to reduce the frequency of those. So dispatch centers are now encouraged or recommended to implement standardized criteria to immediately determine if the patient is in sudden cardiac arrest at the time of the 911 call. So that's being encouraged. This is in addition to CPR, dispatch-assisted CPR, or TCPR, the telecommunicator CPR. They also recommend that these 911 centers or PSAPs track and monitor that diagnostic capability. So in other words, what's their ability to diagnose sudden cardiac arrest from the time of call? Now, we're not saying dispatchers are diagnosing sudden cardiac arrest. What they're saying is identifying that that's a treatable thing and helping walk through the caller on how to perform bystander CPR. You'll hear more about bystander CPR and dispatch and those considerations for the human elements a little bit later. Firm surface CPR. We all have heard, hey, it's better to have that patient on a firm, flat surface. Update here. Effective depth can be achieved even on soft surfaces if the CPR provider increases overall depth to compensate for mattress compression. There's been only marginal benefit seen of putting the patient on a backboard to do chest compressions. They're saying through research that there's more interruption that's happened by putting the patient on a backboard. So the suggestion is put the patient on a firm surface when possible, but they are against moving the patient from the bed to the floor during an in-hospital sudden cardiac arrest. We obviously know that. We have the CPR bed, and you can make the bed firm, or the CPR board that you can put on. So just something to think there. So those are the hot topics. Let me jump into BLS. A lot of us here are BLS folks, and let's start jumping on that. The sequence, compression, airway, and breathing, remains unchanged. We're still doing CAB sequence for all CPR. The interval of 2 minutes of CPR remains unchanged before reassessing vitals. So 2 minutes of CPR remains unchanged. I know all of the AED manufacturers are delighted because all of the AEDs are set up on those algorithms, and I think that's important to note. And guys, if y'all have questions, chime in. I'm just trying to roll through these because I know there's a lot of them. Hand positioning is unchanged. Center of the chest for adults and center of the chest between the nipple line, that remains unchanged. The rhythm check timing is also unchanged. I know that plays in back into the 2 minutes of CPR, but the rhythm check timing is also unchanged. Feedback for CPR quality is unchanged. And so what we're talking about is metronome devices. When we talk about feedback, compression depth and rate in real-world resuscitations, this has nothing to do with training. And while we're talking about this, very important to know, I had an idea, a suspicion that the AHA was going to start recommending via ILCOR compression feedback, compression rate and depth feedback through digital monitoring for infant training during CPR training, so for infant mannequins. And we don't see that right now. We do not see that. Obviously, I think that's a best practice, but we don't see that. So here's interesting. If you've ever heard of cough CPR or the precordial thump or fist pacing, all of that's still not part of the guidelines. But here's what's interesting. The task force did clarify special circumstances where these alternative techniques might be appropriate. So if you're trained in them, I don't know if that's a scope of practice thing, but you can go into the research and the recommendations and see where they might be appropriate. But that's interesting that they brought that up and resurfaced that. Even though it's their recommendations are unchanged, that is a possibility to be able to apply that in a special circumstance. A strong recommendation remains unchanged. It's still a strong recommendation that public access defibrillation programs or PAD programs are highly recommended and they are effective. I encourage you guys to be advocates for public access defibrillation, not just CPR training. All right, an analysis of rhythm during chest compressions. It remains unchanged, but here's something significant. There are new updates that EMS systems are encouraged to integrate artifact filtering algorithms for the analysis of ECG rhythm during CPR. That needs to be assessed in the clinical trial and research initiatives within those EMS agencies. So if I were to say it this way, if EMS agencies are using that to detect artifacts when they're assessing rhythm, they need to do their own internal studies to see if that's actually being used correctly and used well. So that's the recommendation. If you're an EMS officer listening and you're in your EMS agency or fire service, you need to check that out. All right, CPR before defibrillation, that recommendation is unchanged. Something else, removal of foreign body airway obstruction. Okay, so for a severe choking incident in a patient, y'all have probably seen these new, they look like toilet plungers. I don't know how to better describe them, but you put them over the patient's oral nasal pharyngeal airways, and it almost provides suction out of the airway. The AHA is addressing that through ILCOR and saying that the new manual suctions, they were reviewed in 2015. There was one case with only 9 adults, and there was not enough evidence to recommend those new manual suction devices that relieve choking. You know what I'm talking about. They have the yellow ones and things, but they specifically detailed that due to financial costs and training time, they did not decide to, and in the evidence, they did not decide to incorporate that. I'll jump over to questions. Gail, the new guidelines, they are posted on the AHA circulation website. I'm going to post the links here. Greg, good morning. Cheryl, good morning. Glad we have 47 of you guys. Wow. Philip, you need more coffee, huh? So let's kind of jump back in. Here's really interesting stuff here. Really interesting when it comes to choking. Back slaps are used initially in adults and children with foreign body airway obstruction and an ineffective cough. Okay? Back slaps are back. Back blows, back slaps, whatever you want to call them, they are now back, and that's the curriculum change you're going to see. Is instead of starting with instead of starting with abdominal thrust on an adult, and then with the infants, the 5 back blows followed by 5 chest compressions. Now we're going to start seeing, and we're talking about adults and children, back blows, and if that's ineffective, then we start to pick up the abdominal thrust. CPR is still used if the choking patient, severe choking, becomes unresponsive and is now unconscious. They recommend that you manually remove any visible items, but no blind finger sweeps. So the standard still remains no blind finger sweeps. If you are trained in the manual forceps, you can use those, but the suction-based airway clearance devices, like we talked about a moment ago, are not to be routinely used. All right, so big change there. Back blows are back. Crazy stuff. Rachel, yeah, I hope this helps you ahead of your BLS class. But remember, if you're teaching, you can't really teach the new guidelines until you complete the guideline update if you're teaching AHA, so just something to think about there. But this is certainly helpful if you want to preview it for your students. Okay, resuscitation care for suspected opioid-associated emergencies. That recommendation for naloxone and Narcan, those products is not changed, and drowning is not changed. So they made a specific statement to say that harm from CPR to victims not in cardiac arrest is unchanged. Bystander CPR is highly recommended. So if you have a patient who's experiencing an opioid overdose or some other emergency that's unknown to the rescuer, but the patient presents as though they're unconscious and unresponsive, the risk to the patient of harm is minimal at best, and they continue to encourage and emphasize that bystander CPR process happen. So those are the key information on BLS. There's a lot more to unpack, so I want to give you all that time to think about that. Let's jump into ALS. I'm going to give a quick preview on this. I'm going to go super fast on ALS because the predominant amount of the viewers right now are BLS. The other part I wanted to mention is that Carl Daigle, again with Code 1 CPR, is going to be touching on those ALS and PALS updates as they happen, or as he has time. So, targeted temperature management. This is the cold therapy, if you will. There's more research ongoing, and they're saying that that targeted temperature management between 32 degrees Celsius and 36 degrees Celsius is where you want to try to get that patient. They clarified the double sequential defibrillation. That's basically when you have two defibrillators deliver two shocks simultaneously, or one defibrillator deliver two shocks in a very rapid succession. They're saying that that's not recommended for routine use, and they have some discussion there. There's points about IV, intravenous versus IO, intraosseous drug therapy during cardiac arrest, and their recommendation for that now is start with IV. If you're unable to obtain IV on your first attempt, or IV is not feasible, then move to IO, and that's kind of what the big takeaway is there. The point of care ECG for prognostication during CPR. They're against the use of ECG there. I'll just leave it at that. And then they have some new systematic reviews. The cardiac arrest with pulmonary embolism standard is unchanged. The oxygen dose recommendation after ROSC, which is return of spontaneous circulation, remains unchanged. Ventilation strategy after ROSC. There's insufficient evidence for or against targeting mild hypercapnia compared with normocapnia in adults with ROSC after SCA. Okay, so they suggest to not routinely target hypocapnia in adults with ROSC after SCA. If this sounds like a foreign language to you, I'm sorry. I'll be through the ALS in just a moment. Prophylactic antibiotics after sudden cardiac arrest, they're saying that it's not suggested to do that as a preventative measure. Post-sudden cardiac arrest, prophylaxis and treatment. We know that the comatose patients after sudden cardiac arrest, about 20 to 30% of them can experience a seizure. So treat the seizure, but don't use prophylaxis in adults with ROSC. Okay. The prognostication in comatose patients after resuscitation from cardiac arrest, the neuroprognostication always needs to be undertaken with the use of multimodal approach because there's no single modality or test that has sufficient specificity to eliminate false positives. And you can go through the guidelines and it lists 4 or 5 different modalities that you can use to try to determine that. Maria, good morning. Glad you're watching. And guys, thanks for tuning in. My name is Brady McLaughlin, CEO of Go Rescue. Also, Trio Safety is the most recognizable on the CPR brand. And we're just breaking down the 2020 guidelines. They came out literally about 2 hours and 19 minutes ago. And we're going to be posting links here shortly for you to review in detail. There are, by the way, an executive summary that paraphrases some things and gives you general overview, and then there's the guidelines themselves that give the consensus, the rationale, which helps you kind of get a glimpse into what they're thinking. All right, real quick, uh, three things on PALS, Pediatric Advanced Life Support, and actually this is broken into or combined into basic and advanced for pediatrics. The fluid administration rate for septic shock, management of a septic shock. System revision is needed in the near future, so they're not really even saying anything other than they now know that that's needed, and maybe there's going to be some updates soon. Adrenaline and epi initial dose and dose intervals for cardiac arrest. They know that the epi's been there for forever for pediatric sudden cardiac arrest, but they now are saying that more research and data collection is needed, and they hope to move forward with that. Continued evaluation is also needed for management of traumatic shock in infants and children, and you can go read more about that as it relates to traumatic arrest in infants and children. So, guys, y'all are all CPR+AED instructors or know one or are around them, and this is the education implementation and teams information that I think is very important for you guys to know. So, skills decay evidence shows, which we already know, I think, that at 3 to 12 months post-class, I know that's a pretty wide range, retraining more frequently is certainly recommended. However, when it comes to your CPR course completion card, which it's a step short of saying a certification, they're saying that the 2-year recommended renewal interval remains unchanged. So your CPR classes with your clients, that's going to continue to remain at a 2-year interval for renewals. Okay, so no big changes there. But the recommendation is there for continued regular CPR training and retraining. So if you want to approach your clients and tell them, hey, let's do some awareness level training in between certifications, or excuse me, in between course, the AHA courses, that's good. Also, if you want to get them on a 1-year interval, that's up to you, but the 2-year interval remains. Okay. Jumping back on the comments, Corey, glad you're on this morning. Philip, thanks for posting, and we've got a couple of others. The AHA Network has them, and then we'll post the primary source as well. Corey Don Jones, Beverly, good to see you. Stacy, absolutely. Kim, hope you're doing great. Good to see you this morning as well. So let's continue on. This is interesting. EMS experience and exposure, right? EMS is going to be the primary responding entity on the professional healthcare, side when it comes to pre-hospital sudden cardiac arrest, at least to transport the patient. We're not saying that they're the first on scene. We know that bystanders are. But the AHA and ILCOR have said that EMS systems should monitor the exposure of EMS providers, and if they're in an area of low exposure to out-of-hospital sudden cardiac arrest, they need to make sure that these EMS professionals are rotated into areas of higher exposure so that they don't experience skills decay. So that's interesting, and that's interesting in a lot of ways, but that's what the recommendation. Community initiatives to promote BLS implementation. This is all of us, right? That's what we do. That recommendation remains unchanged, and data shows they did 17 studies, and 40% of those 17 studies showed an increase in positive patient outcomes of survivability from pre-hospital to hospital discharge. Nearly all of those cases showed a benefit to the patient in some way, shape, or form with regard to community initiatives for the BLS chain that were implemented. So guys, if I want to give you a pat on the back, this is the time to do it. That means that all of our CPR training, our initiatives to train the community, specifically the lay providers, is paying off. There's a benefit to the patients, and 40% of them showed a positive outcome. Let me say it this way, showed an increase in patient survivability. We're not saying 40% survived. We're looking at sometimes a 3 to 7% hospital discharge survivability. But this means that there's a difference being made, and y'all are a direct credit to that. So way to go, guys. The opioid overdose first aid education remains unchanged. You're going to continue to see that in the curriculum. The willingness to perform bystander CPR guideline or standard remains unchanged, but BLS training should include info to overcome potential barriers to CPR faced by lay rescuers. So we're talking about emotional barriers. Okay, we're talking about physical factors that you have to help them overcome, and specifically they talk about public safety telecommunicators, i.e. 911 dispatchers, and helping identify those barriers, whether emotional, physical, or otherwise, from the caller early on in the arrest response, and trying to help them overcome that. So try to incorporate that into your training. You'll probably hear more about that today. The out-of-hospital CPR training in low-resource environments. Okay. The recommendations to date that ILCOR has published have all been geared towards areas that are well resourced in their response environments. And those have been the primary factors. Okay, but recommendations for agencies in low resource environments are to collect data in the form of registries that comply with the Houston style template. So healthcare system priorities, by the way, this is big. Healthcare system priorities should be determined locally, not corporately, not from a different region, but locally. Here's something significant. Patient outcomes as a result of a member of the resuscitation team attending an ALS course. ACLS training still needs to be completed by healthcare professionals, according to ILCOR, and data shows favor for it, but interestingly enough, that's marginal. In other words, they're saying that the positive impact of attending an ACLS course and that person leaving the ACLS course and then participating as part of a resuscitation team using ACLS interventions, they're only saying that ACLS course makes a marginal impact on the success of that resuscitation. Interesting. I think that goes back to scope of practice, proficiency with the skills in the field, etc. Guys, is this making sense? Am I going too fast? I know it's hard with feedback and it's early in the morning. Try, it's good to see you. But yeah, give me some feedback. If I'm going too fast, let me know. I've just got a few more pages left. But again, I hope this is helpful in some way, shape, or form. All right, so this is another really important thing to share. This is something that stood out to me when it came to spaced learning. So about 2 years ago, in the summer of 2018, the AHA released an education statement. Okay, the education statement had, I think, 8 or 9, maybe 10 different things as relates to contextual learning and how learning needs to happen. And one of the interesting points was spaced learning. What does that mean? Well, if you think about your CPR class, it's at a set time, and at that set moment in time, you learn allegedly everything you're supposed to know. So good. Thank y'all for the feedback. I'm glad that the speed's good and this is making sense. So I appreciate that. I know some of y'all have been up super early, but good. So that's a single moment in time class experience. You could even argue that for the online blended, you have the didactic learning online, and then they show up for your in-person skills session, and then they get certified. But it's a single moment in time. Spaced learning would be that you're exposed continually over a different period of time and to continue that training and certification. Here's what the AHA says. They looked at learners taking CPR classes and compared those outcomes to learners who underwent spaced learning. My best example, and I may be wrong, of spaced learning that we know that we all maybe can relate to now in the context of CPR is going to be the RQI, the little kiosk in hospitals. This is what the AHA and Laerdal are partnered with in the context of hospitals. That's like the perpetual CPR card. Once they get certified, they show up at this kiosk once a quarter, and every 3 months, as long as they do what they're supposed to do, they can keep a CPR card. But here's the interesting thing, very interesting. The 17 studies used mannequins. They did not use real-world patients to measure the competency, if you will, of the students who went through the space learning versus the in-person learning. So check this out. There's low evidence there. It did support spaced learning, and spaced learning may be used instead of single point in time learning. This plays on the RQI thing. I think this just kind of helps them justify RQI. And if any of y'all are involved with RQI, nothing against you. If you want to know my opinions on things, feel free to reach out to me later. Some of you already know. But the point is, it justified RQI, but it didn't really say much else from that. We're using mannequins, not real-world scenarios. So it's interesting. I don't know if there's a lot of stock they're placing in this spaced learning. So in the CPR world, to kind of put this as pedestrian level language for us, that's good. We're going to continue to do CPR training. There's no recommendation that goes away. Your CPR classes are safe. Thumbs up on that. Okay. Pre-hospital termination of resuscitation rules. So what goes into the decision-making matrix of when to terminate, resuscitation, in a home or, on the side of the road or wherever that may be? Advocation for the adaptation of termination guidelines that take into the account the patient's prior wishes, expectations, pre-existing comorbidities, and quality of life before and after sudden cardiac arrest are recommended. All of those should be considered. The rule should not be the sole determinant of when to discontinue resuscitation, though. Okay, it's a conditional recommendation. So there's not many conditional recommendations that the ILCOR releases, but this is one of them. So you kind of need to take a holistic approach if you're making that determination. And most, you're going to see these advanced level care providers making those determinations. So let me jump back into comments. Jazz, good to see you. Gary, has the in-hospital arrest gone up with the places implemented RQI? Gary, that's a great question that I haven't seen any literature on so far this morning. Again, I've been moving as quickly as possible. It's kind of like a post-election analysis, or once the Congress passes a bill, just trying to dig through it to figure out the key points. I haven't seen anything on that, but I'm going to look. I would like to know to see what the impact's been. I would guess that because that the RQI program is so recently implemented, they may not have enough data, but that may be a convenient thing that they don't have enough data right now. All right, go to the station, Greg. Have fun. Glad you hope you have a safe day on shift. And Jamie, will there be a new updated DVD for use during classes to reflect these changes? If so, when will these be available for purchase? The new books, literature, when will these be available? Great questions. I'll go ahead and answer that right now. If you, depending on your training center, you may purchase from Shop CPR, or you may purchase from WorldPoint, or maybe you're purchasing from somewhere else, however you have that set up. Today, the new curriculum is supposed to be released for BLS, ACLS, and PALS. There's been no indication as to when HeartSaver is going to be released and when those changes will happen. And we've checked as recently as this morning to see, and we don't see that. So those will be available today. Bobby, good morning, brother. Good to see you. David, good morning, sir. Hope all's good in your neck of the woods. And yeah, I'm curious as to HeartSaver too, and just give me a moment to tell you my thoughts on that. I would think with AHA specifically, this is just a speculation, we may see a decrease in HeartSaver pricing. Not to alarm anybody, but we may see that. But then again, you never know. We saw what happened on October 3rd, 2017, a day that will never be forgotten in the eyes of CPR instruction world. We don't know what's going to happen or when that's going to happen, but we remain optimistic, and we shall see. All right. The one thing, Gary, you're talking about in-hospital resuscitation, I'll finish this up, is that in-hospital termination of resuscitation, ILCOR is making a strong recommendation against the UN-10 rule as a sole strategy to terminate in-hospital resuscitation. Don't use the UN-10 rule as a sole strategy or a sole determinant factor. So hospital folks, that's for you. All right, moving on to first aid, we have maybe a page and a half left. I know this is a long update, but this is important, and I hope this is helpful. So, the control of life-threatening external bleeding. Uncontrolled bleeding remains the primary cause of death in up to 35% of patients who die from trauma. We know that this is a significant thing, and that's why they are addressing this first off in the first aid recommendations. I guess the point I want to make on that is tourniquets are still good and they're still highly recommended for extremity bleeding that is life-threatening. Here's what's interesting. Direct pressure with or without hemostatic dressings is recommended for those extremity wounds that are life-threatening, but they're not amenable for a tourniquet application. Maybe a tourniquet wouldn't work in that area, maybe the injuries, whatever that may be. Direct pressure with or without hemostatic dressings or gauze. Okay. Methods of glucose administration. We're talking diabetics here. Oral swallowed sugar is preferred to buccal administration of sugar. So if we used to have them put it in the side of their cheek or whatever. They're saying oral ingestion of sugar is better. I guess it's a more direct route. It gets their sugar levels up faster. Something to think about. Sublingual administration of sugar in some children may be a better route. So I think the reason they use some children, and you can go dive into the guidelines yourself, is that depending on the age and their ability to keep any sugar under their tongue, it may be better for them to swallow, but I guess it may be preferred to do that sublingual route for sugar in some children. So consider that. Heat stroke cooling. So exertional hyperthermia or heat stroke is still recommended to be treated with active cooling. Neck down submersion or immersion in water. And the temperature range of that water needs to be 33.8 degrees Fahrenheit to 78.8 degrees Fahrenheit. Pretty large range there, but the recommendation for immersion is to keep them there until their core body temperature is less than 102.2 degrees Fahrenheit. Okay. Stroke recognition, that protocol is unchanged. We know about FAST, face, arm, speech, and time. The supplementary oxygen administration for stroke is also unchanged, and the ILCOR made a statement saying that they are against the routine use of oxygen administration for acute strokes. Okay, aspirin. We know about aspirin. We know that it's traditionally used for chest pain. Early administration of aspirin compared with late administration of aspirin when there's an issue of chest pain, whatever that may present itself as. Early is recommended over late, and they are no longer restricting the administration of aspirin through these guidelines, through ILCOR, to a patient that has chest pain or specifically a possible myocardial infarction. They're saying that any non-traumatic chest pain can be given aspirin, so something unique there. And then the compression wrap for closed extremity joint injuries, that standard is unchanged. And then kind of closing that up is the dental avulsion. So to close up the first aid piece, dental avulsions are now able to be treated with a cling film or plastic wrap to put the teeth in. Okay, two things that have been removed from the treatment protocol are coconut water and egg whites. They're no longer allowed. So if you're getting ready for that fitness routine and you're chugging that coconut water and you're doing whatever you do with your egg whites and something happens to your tooth, you can't put them in there anymore according to the ILCOR guidelines. Okay, so those, in my opinion, are the key takeaways after a few hours of digging through everything. I hope this is, again, helpful. Yeah, Chris, let me jump on comments. Joseph Cooper, good to see you. That does seem really cold to drop someone who has a core temperature of 102 or higher into some water that's nearly freezing. But that's what they're saying, and I think they've done some homework on that. So guys, that's the guideline update. So today we're going to see. I kind of break down what happens next. That's probably important from your perspective. If you're in the AHA realm, you're going to need to talk to your training center. Your training centers are going to issue, as they get informed, training center coordinators. I'm one for Trio Safety CPR+AED. We have not been informed yet, as of this very moment in time, of when those new exam materials are going to be available. But the way the AHA works is they post them for the training center coordinators, and the training center coordinators then distribute them securely to each instructor in each training site. So the program administration piece is going to be unveiled. Just check with your training center coordinator. Be patient with them because they're trying to do the same thing everybody else is doing, trying to figure out what's happening, who's on first, what's on second, and seeing what they need to do to implement things. Something you also are going to want to think about is completing the guideline updates. It's a free course through the AHA. You can complete it through the AHA instructor network page. You're going to need to complete one for each discipline, which is interesting because BLS is coming out, but HeartSaver hasn't so far. So, when HeartSaver comes out, you're going to have to complete it. And the AHA says you have to complete it by February 1st to be able to teach the new 2020 guidelines and issue the new 2020 cards, which, by the way, there are new 2020 cards. But I wanted to answer a question that some people have already asked me, maybe not on here. We have until February 1st to continue to teach the 2015 guidelines. However, effective February 1st, for you to remain current as an instructor, at least through AHA, you're going to have to complete the online instructor update for each discipline you teach, submit that to your training center coordinator, and follow the new guidelines. So you can't just start teaching the new guidelines and the new curriculum without taking that. And then remember, your training center coordinator will dictate kind of when that happens, and then they'll be responsible for helping you get those new curriculum updated. Glad you have a TC that's on top of it, Rachel. That's always a good thing. The cost of BLS cards. So each training center is responsible for setting the card pricing, and the AHA has modestly, I think it was to the tune of 8% increased the BLS e-cards. So that training center will decide what, if any, impact that makes on their cards and your training side as well, and then they'll inform you at that time. I'll tell you, for Trio safety, we are not making any changes on card pricing, and if we do, we will notify everybody on December 1st, and then they will go into effect January 1st. So we're not making any immediate changes on card pricing. We're going to kind of see what happens. Even though we know what the pricing changes are, we're going to see what we can absorb and be more strategic on that instead of making a immediate change on any pricing. We don't know about anything with Heart Saver pricing. We know ACLS and PALS, those card pricings have gone up. Again, a modest increase. Let me run the math. I'll tell you exactly how much that increase was. We're looking at maybe a 9.25% increase on those cards. So Kevin's asking, anything seen on requirements for new training centers or training sites? No, the AHA has not released anything so far as to requirements. I wanted to be clear that this update is really about the guidelines, and then the AHA does administrative changes kind of after those settle down. And so what we've seen in the past, at least, is in the new year usually come new administrative changes. Anyways, Yvette, I see back blows and victim is bending over. I don't know about the position of the victim. What I do know is back blows are now primary, and then if that doesn't work, then the abdominal thrusts are to follow up with that for a conscious adult and child patients with foreign body airway obstruction. So I hope that answers your question. Yeah, keep the questions coming if you have them. Joseph, I hope I answered your question about the grace period and what that looks like as well. So I hope that answers your questions on implementation. Again, we're looking at the same 30-2, the same interval for CPR training every 2 years, the same compression rate per minute of 100 to 120, the same compression depth of 2 to 2.4 inches for adults, about 2 inches for children, and about 1.5 inches for infants, or the AP diameter of the chest. We're looking at like 1/3 AP diameter. So that's, again, what we're looking at there. Today the AHA has a few public guideline updates. Again, those we'll post those on here as well. Those will be on YouTube and on Facebook Live, or if you registered for the virtual release, you can watch that there. I encourage you guys, as a best practice, to learn this stuff early. That way you can kind of be your own subject matter expert and know how to reference the guidelines. Again, give me just a minute. I'll post those here and post the documents that I would recommend you review. But don't take anybody else's word for it. Go to the primary source. Sometimes when these guidelines happen, these updates happen, there's a whole lot of confusion. It's your job to be the ambassador of getting this correct information, not only to the other instructors you know, but to your students, most importantly, and making sure that there's a clear, concise conveyance of knowledge there and answering of questions, and that there's no confusion. Guys, y'all have any more questions? If you're looking for a training center, I'll give a shameless plug. We'd love to help you. Send us an email, training@triosafety.com. We'd love to help you out. We're all about business growth and helping you guys out. There's a ton of fantastic training centers. Some of them you'll see on here. So just find a home that works for you and find the support you need wherever you can find that. Well, guys, I think that wraps it up. It's 6:43 Central. Big day ahead on these guideline releases. A lot to read. I'm going to jump back into the nerd mode and keep reading as much as I can to see what I can find out. But hey, all in all, no real big changes as it comes to how we do our day-to-day. Somebody asked earlier, are we going to see a new DVD? The answer is yes. The AHA is going to make new material, and we know that they've got to make that money. So guys, I hope you all have an awesome day. If you have any questions, send me a ping. If I can help in any way, just add me on Facebook as a friend if we're not already friends. And love to see you guys continue to grow in your CPR instruction. Love y'all long time. Have a awesome guideline release day, and we'll talk to you soon. Goodbye for now. God bless.